Spinal muscular atrophy (SMA) is a genetic neuromuscular disease caused by mutation in the SMN1 gene, leading to a deficiency of the SMN protein and selective generation of lower motor neurons in the spinal cord. As a result, patients gradually lose muscle strength, movement ability, and in several cases, the capacity to breathe independently. This generation means that once motor neurons are lost, the body cannot regenerate them on its own. Traditional therapies may slow progression but do not restore the lost neurons, according to Ebert et al. 2009. Because of this, scientists have turned to stem cell technology, specifically induced pluripotent stem cells, to explore whether it's possible to replace lost motor neurons rather than only manage symptoms, according to Fratini 2015. Thus, for SMA, a disease of neural loss, IPCs-based approach represents a fundamentally different paradigm, not just slowing degeneration, but potentially restoring function by replacing lost motor neurons.
In a landmark study, researchers created IPCs from skin cells of a child with SMA and showed these cells could differently into motor neurons in vitro. These motor neurons retained the disease genotype and demonstrated selective defeats compared to motor neurons derived from a healthy relative faithfully recepting in the pathology of SMA in Culture, PMC and PubMed. Subsequent work using SMA patient-derived IPCs revealed characteristics, pathological features upon neural differentiation, shortened axons and dendrites, increased apoptosis, cell death of spinal motor neurons, and activation of other cell types such as astrocytes, all paralleling aspects of SMA pathology. Moreover, these IPCs-based models allow researchers to test potential therapies in a patient-specific context. For instance, drugs that aim to increase SMN protein levels or protect motor neurons can be screened more effectively using these human-derived neurons, according to Adami 2019. In principle, if such therapy's success and safety concerns are addressed, IPCs-derived healthy motor neurons could be transplanted back into patients, potentially restoring lost connection and muscle function.
The prospect of iPSC-based therapy for SMA has far-reaching implications. If successful, it could shift treatment from symptomatic care or gene modulation toward regenerative therapy, actual replacement of lost neurons, giving patients the chance to regain muscle strength and mobility, improving quality of life and reducing lifelong dependency on supportive care. However, there are critical challenges and risks. First, while in vitro studies show promise, there is currently no approved iPSC-based therapy for SMA. Research remains at the preclinical or early experimental stage. Second, safety. Transplanting stem cell-derived neurons carries a risk of unintended outcomes, abnormal cell growth, tumor formation, immune responses, and etc. Rigorous preclinical testing and strict protocols are essential before any clinical application. And third, cost and accessibility. Developing patient-specific iPSC lines, differentiating them, ensuring safety, and transplanting is technically complex and expensive. And until scalable protocols and regulatory approvals exist, such therapy may remain available only to a limited number of patients. In summary, while iPSC-based therapy for SMA offers a powerful and conceptually transformative approach, actual restoration of lost neurons, it remains a future potential, not a current cure. Continued research, safety, validation, and investment are needed before patients might benefit in reality. Thank you for your attention.